Dear friends, in today's session, we are going to discuss the remaining part of the scapular region and important points regarding the shoulder region. Fine. So, in yesterday's session, we were discussing the scapular region. This was the last slide. Okay. So, we have discussed the various muscles in this diagram and the actions, nerve supply of the various muscles. Okay. You are seeing here. Fine. So, now let's move to the serratus anterior muscle. Okay. And actually, we have discussed this muscle also in the yesterday session. We have discussed it is the muscle of the lateral thoracic wall, and you know the origin of the serratus anterior, right? It arises from the upper 8 ribs by 8 digitations. Okay. And the insertion of the serratus anterior, as you see in this image, the fibers are moving backwards to get inserted into the medial border. Fine. Medial border of scapula along the costal surface, as well as inferior angle of scapula. Fine. And what about the nerve supply of the scapula? Yes. What about the nerve supply of the serratus anterior muscle? Yes. It is supplied by long thoracic nerve. Long thoracic nerve, which is also called as nerve to serratus anterior or nerve of Bell. Fine. What is the root value of the long thoracic nerve? Yes. The long thoracic nerve root value is C5, C6, C7. Okay. What is the peculiarity of the long thoracic nerve? Yes. It arises directly from the roots of the brachial plexus. C5, C6 and C7 roots of the brachial plexus. It directly arises from the roots of the brachial plexus. Fine. And also we have studied the actions of the serratus anterior muscle, isn't it? So it causes protraction, that is forward movement of scapula. So it is called as boxer's muscle. Fine. And it causes overhead abduction of the shoulder joint. Overhead abduction of the shoulder joint. That means 90 to 180 degree abduction. Fine. Along with the trapezius muscle. Fine. Okay. Now, this is a very commonly asked image-based question. Okay. They may ask what is this clinical condition, or they may ask which is the nerve injured in this condition, which muscle is getting paralyzed in this condition, like that. Okay. So any idea about the name of the clinical condition you are seeing in this image? Exactly. The clinical condition is winging of scapula, isn't it? Winging of scapula. What do you mean by winging of scapula? Yeah. Winging of scapula means the medial border. Actually, you are seeing the medial border. The arrow mark is representing the medial border of scapula, okay, which becomes more prominent, okay, okay. It is abnormal. Normally the scapula medial border is not prominent, but in this condition called as winging of scapula, the medial border of scapula will become more prominent, okay, abnormally more prominent, okay. Can you tell me which nerve is getting injured in this condition? Exactly. Injury to the long thoracic nerve. Okay. Injury to long thoracic nerve, obviously resulting in paralysis of serratus anterior muscle, resulting in medial border of the scapula becoming more prominent, called as winging of scapula. Fine. Okay. So obviously in this diagram, as you see here, the right side scapula is becoming more prominent. Okay. That means the right long thoracic nerve got injured, resulting in paralysis of right serratus anterior muscle. Fine. Okay. Now moving to the one muscle present in the shoulder region called as deltoid. Okay. So let's talk about the important points about the deltoid muscle. Okay. So you will be knowing already, deltoid is the muscle which forms the shoulder region. Okay. The shoulder region is formed by the deltoid muscle, isn't it? So deltoid muscle forms the shoulder region. Fine. So you are able to see the deltoid muscle has been labeled in this image. Okay. So I hope you will be knowing the 3 parts or 3 types of fibers of deltoid, right? Anterior fibers, middle or lateral fibers, then posterior fibers of deltoid. Okay. So these are the 3 sets of fibers of deltoid: anterior, middle or lateral, posterior fibers of deltoid. All are continuous with each other. Fine. Okay. So as we know, the anterior fibers of deltoid, when you talk about the origin, of the three sets of fibers of deltoid, anterior fibers arise from lateral 1/3 of clavicle. Okay, lateral 1/3 of clavicle bone. Is it fine? Then what about the middle fibers? I am tracing the origin of middle fibers or acromial fibers of deltoid. Okay, that means why it is called as acromial fibers, because they arise from the acromion process of scapula, so called as acromial fibers or lateral fibers or middle fibers, whatever, right? Okay, now coming to the posterior fibers, you know this is the spine of scapula, isn't it? Right now I am tracing the spine of scapula. So arising from the spine of our spinous process of scapula, we have the posterior fibers of deltoid. So I hope you are clear about the origin of the three fibers of deltoid: anterior fibers, middle or lateral or acromial fibers, all are same. Okay, and origin of the posterior fibers of deltoid, which arise from the spine of scapula. And one more important thing we have to keep in mind is, out of these three sets of fibers of deltoid, fine, anterior fibers and posterior fibers both are unipinnate fibers. Okay, both are unipinnate fibers. Fine, both are unipinnate fibers. What about the middle fibers? Exactly, the middle or acromial or lateral fibers, they are multipinnate fibers. Okay, multipinnate. You can remember as M for M. Middle fibers are multipinnate fibers. Okay, that means if the question is asked like which is the strongest fibers of deltoid, obviously your answer should be exactly middle fibers. Okay, because they are having multipinnate arrangement, isn't it? So the strongest fibers of deltoid will be multipinnate fibers. Okay, strongest fibers of deltoid will be the multipinnate fibers, nothing but middle or acromial fibers. So what is the action of the middle or acromial or lateral fibers of deltoid? Exactly, they cause abduction. They cause abduction of shoulder joint. Any idea about the degree of abduction? Yeah, 15 to 90 degree abduction. 15 to 90 degree abduction of shoulder joint is caused by deltoid, specifically the middle or lateral or acromial fibers of deltoid. Fine. And any idea about the insertion of the deltoid? Any idea about the insertion? As you see here, all the fibers are getting converged into the deltoid tuberosity of humerus. Okay, in the humerus bone, at the lateral side of humerus bone, we have one elevation called as deltoid tuberosity of humerus, which gives insertion to the deltoid muscle. Fine. So it is having a wide origin, narrow insertion. Okay, deltoid muscle. Now coming to the nerve supply of the deltoid, already you will be knowing. You should be able to answer, because in the last session we were discussing about the nerve supply of deltoid. Yes, axillary nerve. Okay, so the nerve supply of deltoid muscle is axillary nerve. What is the root value of axillary nerve? Yes, C5, C6. Fine. Now coming to the, we have discussed the origin, insertion and nerve supply of deltoid, right? Now coming to the actions of deltoid. Okay, you know the three sets of fibers of deltoid: anterior, middle or lateral or acromial. Another one is posterior fibers. Okay, so the anterior fibers of deltoid will cause flexion and medial rotation of shoulder joint. Okay, anterior fiber, so forward movement of shoulder joint called as flexion and medial rotation of shoulder joint. Okay, what about the middle fibers? In the previous slide we have discussed actually. Yes, abduction of shoulder joint. Yes, 15 to 90 degree abduction. 15 to 90 degree abduction of shoulder joint is caused by deltoid. This is the most important action of deltoid muscle. Which one? Abduction of shoulder joint, 15 to 90 degree, caused by acromial fibers of deltoid. Okay, and what about the posterior fibers of deltoid? They are located posteriorly behind the shoulder joint. So when they contract, they will cause backward movement of shoulder joint called as extension and lateral rotation of shoulder joint. Fine. So I hope you are clear about the actions of the deltoid muscle. Actions of deltoid muscle. Okay. all the three sets of fibers of deltoid. Anterior fibers flexion and medial rotation, lateral fibers abduction 15 to 90 degree, posterior fibers extension and lateral rotation. Okay, and if the question is which is the main action of deltoid muscle, as I told already, abduction 15 to 90 degree abduction. Okay, and another question may be all the following movements are performed by deltoid muscle except. So which is the only movement which is not caused by deltoid muscle? Yes, adduction. Okay, adduction of shoulder joint. Except adduction, remaining all movements, flexion, extension, medial rotation, lateral rotation, abduction, all are performed by deltoid. Fine. Okay. Now coming to the applied aspect of the deltoid muscle, you will be knowing in the arm, the muscle which is used for giving intramuscular injection, IM, intramuscular injection is deltoid. Okay. So deltoid muscle is used for giving intramuscular injection. It is given in the lower part of deltoid. Okay. IM injection is given in the lower part of deltoid in order to avoid injury to which nerve? Yes, axillary nerve. Okay. Axillary nerve winds around the surgical neck of humerus deep to the upper part of deltoid. Okay. So in order to avoid injury to the axillary nerve, always IM injection is given in the lower part of deltoid. Fine. Yes. Now let's discuss the important things about the axillary nerve. Okay. As you know, axillary nerve winds around the surgical neck of humerus bone, right? So it is also known as circumflex nerve. Axillary nerve is also known as circumflex nerve because it winds around the surgical neck of humerus. Okay. Can you tell me the source or formation of the axillary nerve? It is a branch from which cord of the brachial plexus? Yes, it is a branch of posterior cord of the brachial plexus. You know the 5 branches from the posterior cord, right? The mnemonic for remembering the 5 branches from the posterior cord will be ULNAR, ulnar, upper and lower subscapular nerves, nerve to latissimus dorsi, axillary nerve and radial nerve. Okay, so axillary nerve is a branch of posterior cord of brachial plexus. You know the root value of axillary nerve C5 C6. Okay, and you know it winds around the posterior circumflex humeral artery. Fine. And this axillary nerve and the posterior circumflex humeral artery both are contents of which space? Yes, both are contents of quadrangular space of the scapular. Okay, quadrangular space of the scapular region. And this axillary nerve will be dividing into 2 divisions, anterior posterior divisions. And you know the branches of the axillary nerve, isn't it? The axillary nerve gives 2 muscular or 2 motor branches to supply the deltoid muscle and the teres minor muscle, and also it gives one cutaneous branch to supply the skin of upper lateral side. Okay, upper lateral side of arm. So that nerve, that cutaneous branch of the axillary nerve is called as upper lateral cutaneous nerve of arm. Upper lateral cutaneous nerve of arm. Fine. So sometimes this may be asked in image based also. So take care of the diagram you are seeing here. This is the surgical neck of humerus. Okay, this is the surgical neck of humerus which is winded around by the axillary nerve. This yellow color is representing axillary nerve. You know axillary nerve is accompanied by posterior circumflex humeral artery. Okay, and you can see anterior circumflex humeral artery also winds around surgical neck from anteriorly, from front. Fine. Okay, and you can see the axillary nerve is dividing into number 1 and number 2. That means the 2 divisions, anterior and posterior divisions of axillary nerve. And it is supplying 2 muscles, namely deltoid and teres minor. And it not only supplies 2 muscles, it gives one cutaneous branch, namely upper lateral cutaneous nerve of arm. Fine. So what is the importance? If there is injury to the axillary nerve, okay, if there is injury to the axillary nerve, you will be knowing which 2 muscles will get paralyzed and where there will be loss of sensation. Okay. Fine. And before moving to the applied aspect, I want you to know this axillary nerve, okay, obeys or follows the so-called Hilton's law, okay, Hilton's law, law of Hilton or Hilton's law. Okay, so what is the so-called Hilton's law? It is nothing but if a nerve supplies a joint, okay, if a nerve supplies a muscle, it may also supply the joint which is acted upon by that particular muscle, as well as, okay, as well as it also, it not only supplies the joint where it is the muscle is acting, it will also supply the skin over the joint, okay, that is called as Hilton's law. Hilton's law is nothing but a nerve supplying a particular muscle, okay, that nerve may also supply the joint where the muscle is acting and the skin over the muscle and the joint, called as Hilton's law. So remember Hilton's law, okay, axillary nerve follows the Hilton's law, because axillary nerve not only supplies the deltoid muscle, also it supplies the skin over the deltoid, and it also supplies the shoulder joint where the deltoid muscle is acting, okay. And one more classical example for nerve following the Hilton's law is nerve to quadratus femoris, nerve to quadratus femoris, okay, which is one of the muscles of the front of thigh, which not only supplies the muscle, also it supplies the hip joint and the skin over the hip joint, okay, nerve to quadratus femoris. So these are the two nerves which are classical example for nerves following the or obeying the Hilton's law. Now coming to the applied aspect of the axillary nerve, you know the three possible causes for axillary nerve injury, isn't it? Fracture of the surgical neck of humerus, fine? Fracture of surgical neck of humerus, then fracture of surgical neck of humerus, then inferior dislocation of shoulder joint, and intramuscular injection. Intramuscular injection when it is given wrongly in the upper part of deltoid, okay. Inappropriate IM injection, fine. Okay, so these are the three possible causes for axillary nerve injury, and you will be knowing the clinical consequences of the axillary nerve injury, isn't it? If there is, because of deltoid muscle paralysis, there will be loss of rounded shape or contour of the shoulder, because deltoid muscle is the one which provides the rounded shape of the shoulder, right? Okay, and you know the main action of deltoid muscle is abduction from 15 to 90 degree. So if there is paralysis of deltoid muscle, there will be loss of abduction from 15 to 90 degree, fine. So coming to the clinical feature, due to teres minor paralysis, there will be weakening of lateral rotation of shoulder joint, okay, weakening of lateral rotation of shoulder joint, fine. And other than this clinical features, one more clinical feature of axillary nerve injury is, you know, upper lateral cutaneous nerve of arm is a branch of axillary nerve. So there will be loss of sensation in the upper lateral aspect of, as it is labeled in this diagram, loss of sensation in the upper lateral aspect of arm, otherwise you can say lower part of deltoid, okay. Upper lateral aspect of arm, it is equivalent to skin over the loss of sensation of skin over the lower half of deltoid, okay, fine. So finally we are going to talk about the three nerves which are in direct contact with the humerus, three nerves which are in direct contact, okay, three nerves which are in direct contact with the humerus bone. So what are the three nerves which are in direct contact with the humerus bone? Yes, you know, in the upper part of the humerus we have the surgical neck, okay, this is the particular area called as surgical neck of humerus, okay, okay, surgical neck of humerus. So can you tell me which nerve I am marking now, which winds around the surgical neck of humerus? Exactly, axillary nerve, isn't it? So this is the axillary nerve which winds around the surgical neck of humerus. Is it fine? Okay. So if there is fracture of the surgical neck of humerus, axillary nerve will get injured. And what will be the clinical features of axillary nerve injury? You will be knowing. In the previous slide we have discussed, isn't it? And can you tell me the nerve I am marking now? Yes, radial nerve. Okay, radial nerve. So radial nerve is related to which part of the humerus? Yes, radial nerve is related to the radial groove, isn't it? Radial groove, otherwise called as spiral groove of humerus. Spiral groove, radial groove or spiral groove of humerus bone. And what is the location of the radial groove or spiral groove? Exactly. It is located at the middle of the shaft of humerus, middle of shaft of humerus. Okay. So what is the importance? Yes. If there is fracture of middle of shaft of humerus, okay, fracture of mid shaft of humerus, radial nerve will get injured. And what will be the clinical consequence of the radial nerve injury? Exactly. If there is injury to the radial nerve, there will be loss of extension of wrist joint. That particular condition is called as, yes, wrist drop. Wrist will be in flexed position. There is loss of extension of wrist. Fine. Okay. And can you tell me which nerve is related to the lower end of the humerus bone? Exactly. This is the ulnar nerve. Okay. This is the ulnar nerve. And this is the medial epicondyle of humerus. Medial epicondyle of humerus. Okay. So if there is fracture, okay, if there is fracture of the medial epicondyle of humerus, what will be the clinical consequence? Due to ulnar nerve injury, okay, ulnar nerve will get injured. So there will be claw hand deformity. Okay. Previously we have discussed 2 or 3 days before in one particular session. Okay. Ulnar nerve injury will result in claw hand deformity. Okay. Claw hand deformity. It is partial or ulnar claw hand deformity. Partial claw hand or ulnar claw hand deformity. Only the medial two fingers will undergo clawing. Okay. So please take care of the 3 nerves which are in direct contact with the humerus bone. Okay. Axillary nerve, radial nerve, ulnar nerve, ARU. Okay. These are the 3 nerves which are in direct contact with the humerus bone. The importance is, if there is fracture of the particular part of the humerus bone, the nerve which is related there will be getting injured. So whatever muscle supplied by that particular nerves, whatever skin supplied by that particular nerve, there will be loss of motor function, loss of sensation. Okay. Fine. That's the end of the today's session. Thank you all.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.